Thank you for the kind invitation. It's been my pleasure. As I apologized this morning in the other session, my Hebrew is not very good, so I'm going to stick with English. My apologies, but I do appreciate this opportunity. Okay, thank you. It's all set up for me. So my title is Diabetic Patients with Acute Coronary Syndromes, Still a Therapeutic Challenge. This is what I plan to go over in my 20 minutes. I will show you my conflicts of interest as it relates to this presentation. I will briefly go over what we know, just give some examples of the outcomes in patients with diabetes as it relates to acute coronary syndromes, talk a little bit about some of the mechanisms involved in platelet dysfunction, which clearly is apparent in patients with diabetes, and then I will restrict my discussion subsequently to antiplatelet therapy in acute coronary syndromes, touch briefly on the glycoprotein 2B3 inhibitors, a little bit even about good old aspirin, and then most excitingly, I think, the opportunity, particularly with the newer ADP receptor antagonists, to potentially improve upon not only platelet dysfunction in diabetes, but in fact clinical outcomes. Here are my conflicts of interest as it relates to my presentation. It's important to note that myself individually, or in particular my research center, receives research grant support and speaker consulting honoraria from companies that make ADP receptor antagonists such as AstraZeneca, Sanofi Aventis and Bristol Myers Squibb, Lilly and Daiichi Sankyo. And then I also, although I won't touch on that today, there are some other, as you're probably aware, antithrombotic thrombin receptor antagonists, etc., that have been studied and are being studied. They're not yet ready for prime time management, but I do some work in some of the clinical trials related to the thrombin receptor antagonists and cangrelor. I could have picked many different examples. This is just one from a clinical trial, a series of patients. The TIMI trials, this should say 1997 to 2006, not 1197, but 62,000 patients from these 11 TIMI trials points out that the frequency of ACS patients with diabetes is, first of all, very common. About 1 in 5 patients with acute coronary syndromes have a prior history of diabetes. As all of you know in clinical practice, this number is probably an underestimate, that many patients have unrecognized diabetes, hyperglycemia, elevated hemoglobin A1C. But even with this, we can see from these curves, first in the ST segment elevation in red with diabetes and the ST elevation without diabetes, you can see that they have a much higher 1-year mortality rate compared to their counterparts without diabetes. Similarly, in the non-ST segment elevation acute coronary syndrome patients, those with unstable angina and non-STEMI, those who have diabetes in red compared to the light blue that don't have diabetes have an increased risk. Now, this is just one example, and it's from a clinical trial, but it's important to note that even after adjusting for characteristics that we know at baseline, like age and other features, are taken into account, diabetes remains an independent predictor of higher mortality, both at 30 days' time and at 1 year's time, regardless of the type of acute coronary syndrome. Now, the experience, I feel a little embarrassed to stand up here and talk about diabetes when we have many experts at the table that I'm sitting at and here, and I just wanted to recognize that, in particular, the strength of the information related to diabetes and the risk is in Israel, and certainly from the descriptions of some of the Israeli colleagues as part of the European heart survey, the ACS surveys. So I just wanted to acknowledge the consistency with the previous study, which was the TIMI group's experience, and there are numerous publications, and I can only briefly recognize some of the folks, some of the co-authors that are here in the audience, including people on the panel today, but there's been a wealth of experience, even in metabolic syndrome, so-called pre-diabetes state, with respect effect to increase risk of adverse outcomes. And then this morning we heard some additional information from Professor Shaun related to recurrent versus first ST segment elevation MI and how important diabetes, for example, as a risk factor was. Now, the platelets of patients with diabetes can be characterized by dysregulation of several signaling pathways. I've simplified this, but obviously it can affect the receptor. For example, there's increased expression of certain pathways, and then there is downstream signaling abnormalities that can contribute to the dysfunction of platelets in setting of diabetes, the end result of which is that this leads to an increase in platelet reactivity. And of course, this dysfunction may play a role in, first of all, a higher risk of developing an acute coronary syndrome to begin with, but then once a patient develops an acute coronary syndrome, a worse outcome, as I've just shown you. And there is some evidence to suggest that a larger proportion of patients with diabetes have an inadequate response to antiplatelet agents, and I'll show some of that data a little bit later on. This is from Dominic Angiolillo, one of the world experts, I believe, on platelet dysfunction and in particular diabetes, and he was kind enough to lend me several of his slides that I've modified slightly to present to you today. One of his earlier descriptions, published in 2007, took 173 type 2 diabetes patients who also had coronary artery disease who were on chronic ASA and Clopidogrel, and he looked at measures of degrees of platelet function, or HPR, standing for high platelet reactivity. He found that the optimum cutoff value was a median of 62%, and he stratified those patients into those in green who had a good response in terms of persistent platelet aggregation or reactivity, compared to those in red whose response to aspirin and Clopidogrel was not as good. And you can see that these patients in red who have less of a response to Clopidogrel and aspirin indeed have a worse prognosis. Now, this is a busy slide. It's taken from an excellent review. If you haven't seen this and you have an interest in this area, I highly recommend that you take a look at this by Professors Ferraro and Angiolillo. Very briefly, there are numerous potential pathways or mechanisms involved in platelet dysfunction in diabetes. Obviously, we know about hyperglycemia. We see this very frequently. Problems in terms of response, deficient insulin response, resistance or action. There are associated metabolic conditions such as dyslipidemia, the inflammation that goes along with acute coronary syndromes, obesity, etc., that can contribute. And then, of course, what we're focusing on mainly today are cellular abnormalities at the level of the platelet and the endothelium that ultimately results in endothelial dysfunction and platelet dysfunction, particularly heightened in diabetes mellitus. Now, before I get into antiplatelet therapies, I would be remiss if I didn't, of course, give a, albeit a narrow view from a cardiologist perspective, but we have to, as cardiologists, not abandon the care of diabetics. And when I say abandon, leave that to our non-cardiology specialists. We need to be actively engaged. We treat hypertension, we treat dyslipidemia, we need to at least have a good understanding of how to manage diabetes. And this is a challenge with all the new therapies, but we can't simply take this somewhat tongue-in-cheek view of Dr. Fisher that says that the cardiologist's view of diabetes is that that's a state of premature cardiovascular death, which may also be associated with chronic hyperglycemia and associated with other conditions. We as cardiologists and involved in the healthcare of acute coronary syndromes and chronic coronary disease have to be aggressive in the management of diabetes. And of course, the first step in dealing with lowering of heightened platelet reactivity are the so-called ABCs. And so we can argue, there are some debate, of course, about what that ideal level should be, but nonetheless, I think we can all agree that some degree of A1C lowering in patients with chronic and acute coronary disease is important. Blood pressure control, clearly, again, we can argue about what level, but importantly can improve platelet dysfunction. And of course, cholesterol lowering, probably a little bit less argument depending on which guideline you look at, but certainly below 2 or 1.8 millimoles per liter would be a target in patients with established vascular disease. Now, when we think about acute coronary thrombosis and a plaque rupture, ulceration or erosion that then leads to a cascade of events, such as platelet activation, adhesion, and aggregation, while at the same time on the surface of every activated platelet is the coagulation cascade, ultimately leading to fibrin formation, which further entraps the red blood cells in the platelets to form an organized thrombus or clot. But of course, in the acute phases and in the chronic phases, this can often be the thrombus can be very platelet rich. And what I've done in the green circles around the platelet and coagulation cascades is talked about a variety of medical and mechanical therapies that we have to deal with acute coronary thrombosis. Today I will only focus, as I mentioned briefly as it relates to diabetes, on aspirin, glycoprotein 2B3 inhibitors, and ADP receptor antagonists, but this is just one part, of course, of our management of dealing with acute coronary thrombosis. Now here's an outline of some of the therapies. We have parenteral agents, obviously used in the acute phase, glycoprotein 2B3 inhibitors. We have oral agents such as ASA, aspirin. We have the P2Y12 receptor antagonists. And again, I won't talk about some of the other agents that are available. I believe cilostazol, for example, in my country and your country is not available. But there is some information related to some of these other agents in terms of their impact on platelet function and outcomes with respect to diabetes. First, the glycoprotein 2B3 inhibitors. This is not new information, published back in 2000. Rofi et al. Looked at the totality of the large-scale outcome trials and argued that in the subgroup of patients with diabetes, the 30-day mortality rates were significantly lowered with the use of an intravenous glycoprotein 2B3 inhibitor compared to a placebo. So there is a potential advantage upstream to giving a 2B3 inhibitor in patients with diabetes, and this is a subgroup analysis, but fairly powerful information. Now, what about aspirin oral agents? We know that the use of antiplatelet therapies, particularly ASA or aspirin, in acute MI and a variety of settings, overall leads to a reduction in vascular events, particularly mortality, and that's a mainstay of our treatment. It's interesting to look at 1994 analysis by the Antiplatelet Antithrombotic Trialist Collaboration to see where we have specific information on the management of patients with diabetes, and you can see that the absolute benefit per 1,000 patients treated was comparable in those who did not or who did have a history of diabetes, obviously recognizing that those with diabetes are at the very highest risk of having vascular events, and this can be reduced. This treatment benefit is pronounced in those patients who have diabetes and receive something like aspirin. But we know that aspirin as monotherapy, as a single antiplatelet agent, is not enough. This is one of my favorite advertisements from Bayer. You can tell it's very old. First of all, in my country, the nurses don't wear hats anymore. But importantly, Bayer took great pride in promoting to the general public how safe aspirin was because it doesn't affect the heart. So that tells you how old this advertisement is. We, of course, know better. And this is one of the original bottles that Felix Hoffman made of ASA, of aspirin, and it's a great drug, and as I just showed you, it lowers mortality, including in diabetics, but we can't rely on it as a single antiplatelet agent. What is the evidence to support that statement that I just made? We're all familiar with the CURE trial that took patients with non-ST elevation acute coronary syndromes. All of them received aspirin and anticoagulants and statins and all the other usual therapies, but they were randomized to 300 milligrams of Clopidogrel, followed by 75 milligrams a day, compared to placebo out to 1 year's time. A very impressive reduction in the endpoint of cardiovascular death, myocardial infarction, and stroke with dual antiplatelet therapy, aspirin and Clopidogrel, compared to monotherapy, just aspirin by itself. Now, there is consistency of the benefit if you go to the subgroup analysis and you look at those 23% of patients, the 2,800 patients that had a prior history of diabetes. You can see, without a statistical comparison, because that's not as important here, but you can see that the absolute 2 to 3% benefit in reduction of cardiovascular death, MI, and stroke is very consistent amongst those with and without diabetes. So this dual therapy works equally well in diabetics as it does in non-diabetic ACS patients. Now, Clopidogrel and aspirin are great drugs, and this is the glass half full, but we know that these patients continue to be at risk for events. This is the glass half empty. So there are some limitations of Clopidogrel that we're all aware of. There is a delayed onset of action, particularly with standard dosing, 300 milligram loading of Clopidogrel. There is a large between patient variability in platelet response. There are good responders, there are less good responders, and there are very poor responders to Clopidogrel. And finally, there is irreversibility of the inhibitory effect on platelets. That means that we often have to delay things like bypass surgery. Just like aspirin, when Clopidogrel is given, it binds irreversibly to the platelet, to the ADP receptor in this case, for the life of the platelet. So we also know that in particular in diabetes, that the risk of stent thrombosis at 1 year's time, even in the era of drug-eluting stents, we know that diabetes is often an independent predictor. And this is a setting, of course, where we need dual antiplatelet therapy in general, but maybe particularly in the case potent dual antiplatelet therapy for those who have diabetes. Now, Dr. Angiolillo looked at both the acute and the longer-term phase in terms of the influence of diabetes on Clopidogrel-induced antiplatelet effects. First, I'd like to show you in the diabetics compared to the non-diabetics, and you won't be surprised by this information, but the proportion of patients that are so-called non-responders or low responders is much higher, almost half of the patients in diabetes compared to about 22% that don't have diabetes. And this is a problem also not just acutely in the acute phase after loading a patient with 300 milligrams of Clopidogrel, but in the so-called chronic maintenance phase with 75 milligrams daily of Clopidogrel. Depending on which degree of stimulation with ADP you use, there is consistently a lower response. In this case, this is the percentage of platelet aggregation, so therefore the bars are higher in the orange, those patients with diabetes. There is a lower response and therefore a higher degree of persistent platelet aggregation in patients who have diabetes compared to those who do not. And I already showed you a mechanism slide, but there are some specific areas that have been researched related to the impaired response of Clopidogrel in patients with diabetes, and we've talked about some of these already. There is in particular, I want to focus on some evidence of upregulation of the ADP P2Y12 receptor and the signaling related to that, and there may be indeed increased exposure in diabetes to ADP. And so that's why when we now turn to the novel or newer ADP receptor antagonists, there is hope that these newer agents will provide more potent platelet inhibition compared to, for example, Clopidogrel. Now, just to take a step back and talk in general about Clopidogrel, and one of the reasons why there are limitations with this treatment, you are aware that it is a prodrug. Most of it is inactivated in the gut by esterases, and that drug that does get to the liver requires a two-step oxidation process before it ultimately becomes an active compound that binds to the ADP, the P2Y12 receptor, and renders this platelet unable to stick to its neighbors and help form platelet aggregation in a platelet plug. And we know that this two-step process is susceptible to interference of genetic polymorphisms. I've listed some of them here. In particular, there's been a lot of work with CYP2C19 and potentially drug-drug interactions. There are other treatments that we give patients. There's a whole debate about proton pump inhibitors, some of them which share some of the same pathways in the liver in terms of the metabolism of Clopidogrel. What are the options to overcome some of these problems? Well, we can give more clopidogrel. We could give a higher loading dose and a higher maintenance dose. And as you know, this was done in the current OASIS 7 trial, where patients were randomized to get standard dosing versus so-called double or higher dosing, a 600 milligram load followed by 150 milligrams for the first week, the next 6 days, before dropping down to the maintenance dose of 75 milligrams. Now, disappointingly, the overall results in this 25,000 patient study did not show an advantage of double dosing clopidogrel in reducing cardiovascular death, myocardial infarction, and stroke. But it did cause an increased risk of bleeding. So overall in ACS patients, no advantage of doubling the dose and paying a price with increased bleeding. However, there was an important subgroup that was pre-specified, those patients who actively went on to PCI, to percutaneous coronary intervention, and in that group, published in The Lancet, we can see that there is an advantage to double dosing. The most classical example for us would be a patient who presents with ST segment elevation myocardial infarction that is being taken to the cath lab very early for primary PCI. That's a patient that would, in theory, benefit from a double dosing compared to standard dosing of clopidogrel. But this isn't always obvious for us in the emergency departments which patients will or will not benefit from double dosing. Stent thrombosis was also reduced in those patients. And if we look in the PCI-treated patients at the diabetic cohort, there is at least, again, consistency of the double dosing compared to the standard dosing benefit in both diabetics and non-diabetics, recognizing that the individual groups may not achieve statistical significance, but the p-value for interaction is not significant, suggesting that regardless of diabetes status, in the PCI-treated patients, double dosing was better. Now, Dr. Angelillo did the Optimus 1 study in patients with diabetes and looked at a comparison of 75 milligrams to 150 milligrams. This was the maintenance dose for at least 6 days that was used in the OASIS 7 current study. And you can see the percentage of platelet inhibition on the left and another measure with the Verify Now assay, the P2Y12 reactivity on the right. And you can see that certainly the percentage of patients that get a higher degree of inhibition of aggregation was seen with 150 compared to 75, and similarly the reactivity was lower in the 150 compared to the 75 milligrams daily. Despite that, you can see that still the majority of diabetic patients still had a so-called suboptimal response to clopidogrel. So increasing the dose helps, but maybe not ideally where we want to go. Well, what is an additional option? Using a better inhibitor of the P2Y12 receptor, and we know one of those is Prasugrel. Prasugrel is very similar to clopidogrel, except that it only requires a one-step process in the liver in terms of oxidation, and so it gets there in a faster and higher amount, and so the degree of platelet inhibition is much more potent with Prasugrel compared to clopidogrel. In diabetic patients, the Optimus 3 study compared 35 patients with type 2 diabetes and stable coronary artery disease, again looking at a measure, a surrogate of clinical outcomes, a degree of percentage of inhibition, and you can see in green that both with a 60 milligram loading dose of Prasugrel compared to, in blue, a 600 milligram loading dose of clopidogrel, and in the maintenance dosing phase of 10 milligrams of Prasugrel in green and 150 milligrams of clopidogrel in blue, that there are statistically significant advantages. There is a greater degree of inhibition of platelets in the diabetic who receives Prasugrel loading and maintenance dose compared to clopidogrel double dosing. There are a number of other measures which I won't show you in the interest of time, but there are consistency of the results, and also Prasugrel resulted in fewer poor responders at all time points, regardless of whatever definition one might use. Well, what about the clinical outcomes? Well, we know from the Triton-TIMI 38, and Israel played a key role in this trial under the guidance of Professor Gottlieb. 13,000 patients were enrolled. Those patients were undergoing PCI. They all had an acute coronary syndrome, and a 60 milligram load followed by 10 milligrams daily of Prasugrel compared to a 300 milligram load followed by 75 milligrams daily of Clopidogrel resulted in an important benefit in a reduction of cardiovascular death, MI, and stroke with Prasugrel compared to Clopidogrel over a median follow-up of 14 and a half months. I just want to point out that this benefit is probably not only from the loading dose in the first few days of Prasugrel over Clopidogrel, but also by landmark analysis when you reset the clock to 0 and follow from day 3 all the way out to day 450, there is incremental benefit of having an agent on board that is more potent, such as Prasugrel compared to Clopidogrel. Some people have argued that because cardiovascular death mortality by itself was not statistically significantly lowered, that maybe we shouldn't use Prasugrel compared to Clopidogrel. Two problems with that. One is the study was not powered to look at mortality alone. And two, when we look at myocardial infarction reduction, these are important, not just peri-procedural MI reductions, but even so-called spontaneous MI that occurs over the course of time and is not always related to the site of the stent or the original culprit stenosis. Indeed, stent thrombosis was dramatically reduced, about a 50% relative reduction with Prasugrel as compared to Clopidogrel. Now, in the STEMI cohort, which included both primary PCI and those with so-called secondary PCI, those patients who did not get a primary PCI or did not get, may have got lysis, and there were more than 24 hours later, who then came to the cath lab and were randomized, you can see consistency of the benefit of Prasugrel in yellow over Clopidogrel in blue, very consistent with the overall trial results, both at an early time frame at 30 days and, of course, over the course of 1.5 or so years. Interestingly, again, although the study wasn't powered to look at mortality alone, there is a hint that cardiovascular mortality and all-cause mortality is certainly moving in the right direction with a more potent inhibitor of platelet aggregation, Prasugrel, compared to Clopidogrel. Now, this slide or this content has been the source of a lot of discussion. It has led some countries in the world to list as a specific or preferential indication for Prasugrel use this status, diabetes or not. I was a co-author on this paper with Stephen Wiviot, and I think it's a very important result, but I just want to clarify something. So, of course, when we look at the patients with diabetes on the left-hand side, we see that their event rates in both groups are higher than those on the right-hand side. And, of course, the absolute benefit is much greater with Prasugrel compared to Clopidogrel in diabetics compared to non-diabetics. But it's not to say that Prasugrel didn't work better than Clopidogrel in the non-diabetics. Both of them, in fact, are statistically significant, and I would not place too much emphasis in a subgroup analysis on a quantitative difference of 0.7 versus 0.86. What's most important is there any difference in the treatment effect across the status of diabetes or no diabetes? And P interaction is not statistically significant. So what this tells us is that regardless of the diabetes status, yes or no, there is consistent reduction with Prasugrel over Clopidogrel. Yes, the absolute benefit is higher, and therefore the number needed to treat will be even smaller or lower in diabetes compared to no diabetes. But Prasugrel is better whether you're diabetic or not. I just wanted to mention, because Dr. Gottlieb and myself and others are involved in this study, this is another area that we'll learn at the European Society of Cardiology meeting, where there might be a potential additional role of Prasugrel beyond the revascularized patient population. This is the Trilogy ACS study that is taking medically managed non-ST elevation acute coronary syndrome patients and randomizing them to Clopidogrel or Prasugrel in a lower dose, in part because of some of the concerns related to increased bleeding risk in low body weight and elderly individuals in the PCI trial in Triton-TIMI 38. So this event rate was even higher than we anticipated, so the sample size is actually lower than we anticipated. It's just under 10,000 patients. We're just in the process of locking the database, and this will be presented, the overall results, at the European Society of Cardiology meeting. Now, the final option from a P2Y12 inhibitor perspective is to think about a different type of P2Y12 inhibitor, ticagrelor. And ticagrelor is not a thienopyridine. It's different than Prasugrel and Clopidogrel. It doesn't require any in vivo biotransformation. There is some oxidation in the liver, but it's already of an active compound, and so this is simply an active metabolite. And so it goes to the receptor, and it binds reversibly to the receptor. So it has a slightly different mechanism of action compared to Prasugrel and Clopidogrel. And you're well aware of the Plato trial results that took the spectrum of acute coronary syndrome patients, except for those who got fibrinolysis, who were excluded from the trial, and showed that ticagrelor was better than whatever dose of Clopidogrel, loading dose, was used over the course of time in reducing cardiovascular death, MI, and stroke. What about the diabetes cohort? Stefan James has published this in the European Heart Journal. You can see in the diabetics, again, a much higher rate compared to the non-diabetics, but the consistency of the benefit of the more potent agent, ticagrelor over Clopidogrel, is seen here. Again, the hazard ratios, and in particular the confidence intervals, are not in the diabetics, don't achieve statistical significance, but I would not be troubled by that. It's more important, again, to look at the p-value for interaction, which suggests it's not significant. There is no lack of consistency whether you're diabetic or non-diabetic, and you should expect that there would be a benefit in diabetics and non-diabetics with ticagrelor over Clopidogrel. Now, finally, in this summary paper, Drs. Ferrero and Angelillo did a summary. This is a cross-trial comparison, and we have to be cautious of this because all of these agents were compared to either standard or, in some cases, double dosing Clopidogrel, but it isn't meant to say we can be certain about the effects of Prasugrel versus ticagrelor, for example, because we don't have that trial. What I'd like to look at is, again, the consistency of the benefit of the more potent antiplatelet regimens or newer agents, particularly in diabetics. So what they published here and they argued is that there's consistency of the benefit. In Triton, it was statistically significant. In Plato and current Oasis, it was not statistically significant. But the odds ratios are all in favor of either the newer drugs, ticagrelor, Prasugrel, or dosing regimens, double dosing compared to single dosing, at least in the PCI cohort. But I've added to the slide because, again, that's not the most appropriate way to reach a conclusion about the impact in diabetics compared to the rest of the population. To do that, you need to look at the non-diabetics. But the good news is that things are very consistent qualitatively, not always statistically significant, but these are subgroup analyses. We wouldn't always expect statistical significance. But I think that there's consistency across these findings, and as I've shown you, the p-value for interactions in all trials were not significant. So what this means is overall, there is consistency of benefit of the newer agents. Prasugrel, ticagrelor, and potentially double compared to standard dosing of Clopidogrel in the PCI cohort. Now, I've given you a lot of information, and this is probably how you're feeling, and your stomach is probably doing the same thing because you're looking forward to the main course. Let me summarize and conclude. Patients with diabetes have platelet dysfunction. They have increased platelet reactivity. They have reduced responsiveness to antiplatelet agents that we routinely use in their management. It's important as cardiologists not to forget that we are part of the team in managing in general diabetes and making sure that we follow the ABCs in addition to choosing the right and most optimal antiplatelet regimens. We know that with this increased platelet reactivity and reduced responsiveness to standard dual antiplatelet treatment, i.e. the previous gold standard, aspirin and standard dosing Clopidogrel, unfortunately, in particular in diabetes, patients remain at increased risk. these abnormalities may warrant us specifically tailoring our drug regimens now that we have more options beyond just standard dosing clopidogrel and aspirin. And I think that the introduction of the new agents, particularly Prasugrel and Ticagrelor, will enable more efficient blockade in the patient who has diabetes. Thank you very much for your attention.